Welcome to Buprenorphine in Pregnancy, Training for Obstetricians, Module 1. This course is a partnership between the Florida and Tennessee Perinatal Quality Collaboratives and is designed to help obstetricians develop comfort with prescribing buprenorphine for pregnant people. It is a two-part series. The first focuses on an overview of OUD in pregnancy and treatment options with a focus on buprenorphine. Part 2 of the series focuses on practical management of buprenorphine in an obstetric practice. I'm Dr. Jessica Young. I am an obstetrician gynecologist and addiction medicine specialist. I am the maternal director of Firefly, which is a program at Vanderbilt University Medical Center that integrates substance use disorder treatment with obstetric and postpartum and well woman care. I am also the maternal medical director of the Tennessee Initiative for Perinatal Quality Care. Recently, the rules around who can prescribe buprenorphine relaxed. This presentation is designed to help obstetricians incorporate buprenorphine into their practice. I have no disclosures. Why is this important? I'd like to start with a story. I met Rachel when she was 2 weeks postpartum after she had her children, including her newborn, removed from her custody. She has opioid use disorder and was unable to find treatment during pregnancy. She did not want to continue using heroin, so she transitioned herself to buprenorphine. She got prenatal care, but she wasn't able to get into a Suboxone clinic. After delivery, her newborn and other children were placed in foster care because Rachel did not have a prescription for buprenorphine. Could this outcome have been avoided if her OB had been able to prescribe bup for her? Do you have a patient that you have encountered where having access to OUD treatment would have improved care? The 3 key ideas we will focus on today are giving an overview of opioid use disorder in pregnancy, getting familiar with buprenorphine basics, and highlighting some pregnancy pearls around the management of OUD in pregnancy. Let's get started with an overview of opioid use disorder. I think we are all familiar with the toll OUD has had in this country over the last decade or so. The U.S. leads the world in drug-related deaths, and we have continued to see an increase in overdose deaths with the flooding of synthetic opioids like fentanyl into the illicit drug market. These national trends affect both pregnant people and their infants. We are all familiar with the increase in infants diagnosed with neonatal abstinence syndrome since the early 2000s and that economic burden. The overdose death among women has increased by 20%, and OUD in pregnant people has quadrupled. During COVID, we've seen a massive surge in drug overdoses, with 93,000 Americans dying of overdose in 2021. This is true for both Florida and Tennessee. Without access to evidence-based treatment, we won't be able to combat this. But how does this affect pregnant women? This is maternal mortality data from Florida, and you can see drug-related deaths outpacing the other causes of pregnancy-associated deaths. The rate of Florida women with opioid use disorder identified at delivery admission quadrupled from 0.5 per 1,000 deliveries in 1999 to 6.6 in 2014. Use of illicit opioids and related drugs is now increasing as prescription opioids are becoming more restricted. There are now as many maternal drug-related deaths in Florida as deaths due to traditional causes of maternal mortality. Neonatal abstinence syndrome, or neonatal opioid withdrawal syndrome, continues to be an issue in Florida. In Tennessee, the story is much the same, with 33% of pregnancy-associated deaths being substance-related. In a study from my colleague, Dr. Stephen Patrick, we see that in Tennessee, pregnant people have a harder time obtaining a buprenorphine prescription compared to non-pregnant people. Improving treatment and caring for opioid use disorder in pregnancy will save lives. 96% of Tennessee maternal mortality related to substance use disorder was determined to be preventable. NAS NOWS was really the canary in the coal mine for Tennessee over a decade ago and helped us begin to understand the scope of this issue for pregnant people. I think we all understand that opioid use disorder in pregnancy causes and is related to many risks, including delayed or limited prenatal care, housing and food insecurity, and trauma. Part of that is related to the cycle of intoxication and withdrawal that a pregnant person with opioid use disorder often finds themselves in. Access to MAT or medication-assisted treatment can be the key to stopping this cycle. While many of these pregnancy complications, such as preterm labor, are more related to active substance use disorder, some theorize that chronic opioid exposure itself increases the risk of fetal growth restriction. The primary risk to baby is around NAS NOWs and the increased lengths of stay that we often see for babies needing treatment. But of course, for the preterm infant, there are also complications of prematurity. The current data on the future neurocognitive delays are mixed, and further study is needed. There are three main treatment modalities for opioid use disorder: medication-assisted treatment, MAT, or medication for opioid use disorder, MOUD, is the evidence-based mainstay of treatment. This category includes methadone, buprenorphine, and naltrexone. Medication-assisted withdrawal is less studied in pregnancy and is commonly used to stabilize someone who desires abstinence-based treatment. Psychosocial support, whether that is individual or group, is an important treatment modality regardless of whether the patient is on medication or not. For medications, we will start with talking about methadone. Though this series focuses on buprenorphine, it is important to know about all treatment options so patients can make informed decisions about their treatment. Methadone has been used for treatment of opioid use disorder in pregnancy since the 1970s. It is a long-acting opioid agonist and prevents cravings and relapse by fully occupying the opioid receptors. It has been shown to improve outcomes compared to pregnant people who continue to use during pregnancy. Methadone is highly regulated and can only be dispensed for the treatment of opioid use disorder in a federally licensed opioid treatment program. Accessibility can be an issue, particularly for rural patients. It requires daily visits to take the dose. This can cause accessibility issues. Because it is a full agonist, there is risk of overdose when combined with other substances. The risk of NAS NOWs is about 50%. We'll dive more into the specifics of buprenorphine later, but buprenorphine has been used in pregnancy for over a decade. Compared to methadone, it is thought to have less severe NAS with shorter hospital stays. It is more accessible as an office-based treatment. It can be harder to start due to the risk of precipitated withdrawal and has higher dropout and relapse rates compared to methadone. It may be less effective for people injecting higher doses of heroin or fentanyl. NAS NOWs rates are 20 to 45%. Prescribers must obtain a DEA waiver to prescribe. What about medically assisted withdrawal or detox? This is typically done with methadone or buprenorphine with stabilization on either medications and then either a slow or fast taper off them. This can be done inpatient or outpatient and requires intensive behavioral therapy and support. The benefits of medication-assisted withdrawal are that it reduces risk of NAS if successful, and it also can decrease risk of Child Protective Services involvement, which can be advantageous in states where their models are more punitive than therapeutic. It also can be more supported by families or in certain recovery communities. The downside is that this is treating a chronic disease with a short-term solution. The risk of relapse is significant, and patients are at the highest risk of overdose after completion of detox. There is a shortage of residential treatment programs, and sober living housing for pregnant people are few, and even fewer exist that allow children. There are also risks to withdrawal without adequate supervision. A newer and still experimental therapy in pregnancy is naltrexone. It is a complete opioid receptor blocker. It is a monthly injection or a daily pill. Naltrexone requires a period of abstinence prior to initiation, and that period is generally 7 to 14 days. Ideally, naltrexone is started in a residential treatment program. It can likely be continued safely in pregnancy for those on it prior to pregnancy. Pain management can be challenging, so there are protocols on switching someone from the injection naltrexone to tablets at around 35 weeks of pregnancy. How do you choose what treatment to offer? Listen, gather data on past treatment, what's accessible, the environment they live in, and their support systems. Educate the patient on their options, risks, and benefits. By using a shared decision-making framework, the patient and the provider can develop a plan. Our second key idea will be diving into buprenorphine basics. Buprenorphine is a partial mu opioid receptor agonist and a kappa opioid antagonist. It has one of the highest affinities for opioid receptors and binds strongly without fully activating. Lower doses of buprenorphine prevent withdrawal symptoms. Higher doses prevent cravings. There are several formulations, but what is currently used for treatment of opioid use disorder in pregnancy are buprenorphine tablets or films. In order to start, aka induce buprenorphine, the patient must be in moderate withdrawal. If they are not in moderate withdrawal, buprenorphine will cause precipitated withdrawal. A clinical opioid withdrawal scale of at least 10 to 12 is needed prior to the first dose. Where do we start this? Home induction is generally not recommended in pregnancy. Often induction can be done in the first and second trimester. However, a patient must be in moderate withdrawal to give the first dose of buprenorphine. Generally, this requires daily visits for 3 to 5 days. For a hospital induction, this is recommended for either an unstable patient or someone at 24 or more weeks gestation. This is all dependent on what is available in your office setting and your community. The COWS scale, or the Clinical Opioid Withdrawal Scale, is an important tool in buprenorphine induction. It is typically nursing administered and measures the severity of opioid withdrawal based on both objective and subjective measures. A COWS score of greater than 10 is required before first dose of buprenorphine. This is an example of a flow chart for buprenorphine induction in pregnancy from the buprenorphine ASAM X-waiver training. Regardless of the pathway, the patient needs to abstain from opioids for 12 to 24 hours and have a COWS greater than 10. The test dose of buprenorphine is 2 to 4 milligrams. If there is no precipitated withdrawal with that test dose, the buprenorphine dose is titrated up. It is easier to get someone on the dose that they need more quickly in an inpatient setting. I want to say something briefly now about fentanyl withdrawal. We are seeing more heroin being laced with fentanyl or being entirely replaced by fentanyl. This can make starting buprenorphine more challenging, as the synthetic fentanyls have longer half-lives. People may not have adequate withdrawal to start buprenorphine until 24 to 48 hours after their last use, and this can be hard for them to tolerate. New protocols are using microdosing of buprenorphine or stabilizing a patient on an opioid agonist like hydromorphone and then starting bup induction. This is beyond the scope of this presentation, but it is important that you are aware of this issue. Which formulations of buprenorphine should you use? There are 2 formulations of bup products used in pregnancy: combo product and mono product. Combo product is buprenorphine with naloxone. This can be in pill or film form. Mono product is plain buprenorphine and it is a tablet. All are sublingual and require a patient to dissolve it underneath their tongue. Oral administration is less effective and causes significant GI side effects. Traditionally, we have used mono product or plain buprenorphine in pregnancy. This was what was studied in the MOTHER trial. However, there is increased risk of diversion and misuse, like snorting or injecting with the plain buprenorphine or mono product, and so there is renewed interest in using combo product in pregnancy. There is newer data that buprenorphine naloxone is safe in pregnancy. Both combo and mono product are safe with breastfeeding. Side effects of buprenorphine include nausea, vomiting, and constipation, headache, restless legs, and sweating. Frequently pregnant people on buprenorphine will need a bowel regimen to combat constipation. This is an example of a buprenorphine quick start guide in pregnancy from California emergency rooms. Notice the high test dose of 8 milligrams. The benefit of a higher test dose is that it will get you to where you need to go more quickly. However, it is more likely to precipitate withdrawal and should be done with caution. What total dose of buprenorphine is needed? 8 milligrams is usually enough to control withdrawal symptoms, but frequently 12 to 16 milligrams is needed to control cravings. Doses of 20 to 24 milligrams may be needed for those using high doses of IV opiates. Pregnant people are more likely to require doses above 16 milligrams due to the increased metabolism of pregnancy. Neonatal abstinence syndrome, or NABS, is not dose dependent. These are the key elements of an initial assessment for opioid use disorder in pregnancy, and this includes a substance use history, a mental health history, a physical exam, urine toxicology, pregnancy confirmation and dating, patient education, and informed consent. After induction on buprenorphine, the next phase is the stabilization phase. I recommend weekly visits for at least a month, group and/or individual therapy, weekly urine toxicology. Intensive outpatient programs or residential treatment programs are sometimes needed during the stabilization phase. After a month of no relapses, patients can progress to maintenance phase. In that phase, visits are every 2 to 4 weeks and still include group and individual support. Moving on to our last key idea, pregnancy pearls. These are the evaluations, assessments needed for pregnant women with opioid use disorder. We do serial growth scans starting at 24 weeks, but do not do antenatal testing unless otherwise indicated. The biggest consideration with intrapartum management is pain control. You do not need to stop or reduce buprenorphine prior to delivery. For vaginal deliveries, epidural analgesia works well, and postpartum, we continue buprenorphine and schedule NSAIDs. For cesarean deliveries, regional analgesia is effective, and using hydromorphone in the spinal can be helpful. Intra-abdominal muscle blocks can be also used. Postpartum, dividing the buprenorphine dose can help with analgesia, and often additional short-acting opioid agonists are needed. Hydromorphone may be more effective than oxycodone or hydrocodone due to how it binds to the opioid receptors. Multimodal therapies can be very helpful and reduce opioid requirements, and those include NSAIDs, gabapentin, muscle relaxers, abdominal binders, and early ambulation. Breastfeeding is safe for women who are maintained on methadone or buprenorphine and should be supported unless contraindicated. Breastfeeding decreases severity of NAS, promotes mother-infant bonding, increases maternal self-esteem, and should be promoted if there's no illicit use within 90 days before delivery. At our institution, we allow breastfeeding if there's no relapse in 30 days. Developing a postpartum plan of care is important for all OUD patients, regardless of whether you are providing MAT for them. Highlights include overdose education and naloxone provision, making a contraception plan, educating on postpartum care and post-birth warning signs, ensuring continued treatment for opioid use disorder, and screening for postpartum mood and anxiety disorders. Having a warm handoff between inpatient and outpatient providers, while challenging, can be key to eliminating gaps in patient care. Postpartum relapse is common, and often the postpartum period is stressful. Dosing changes may be needed, either increase or decrease. We see our opioid use disorder patients at 1 to 2 weeks postpartum, and then at least every 2 to 4 weeks after. Embracing the concept of the 4th trimester and the paradigm shift in postpartum care can be very helpful for this patient population. This includes linkage to behavioral health, hepatitis C treatment, and any other chronic health condition needs. The foundation of all this care must be trauma-informed. Most women with opioid use disorder have some sort of trauma in their past, whether that is as children or adults. Get trained in trauma-informed care yourself. Encourage your staff and colleagues to do so as well. Ask yourself what might be underlying a difficult behavior or relapse. Ask permission to discuss difficult topics or prior to exams. I consider harm reduction principles as foundational as well. This can include overdose education, needle exchange referrals depending on your state laws, but it also includes not turning people away from care and not firing people for relapse. An X waiver is required to prescribe buprenorphine. See the link here to apply. To prescribe for a 30-patient limit, the 8-hour training course is waived. All you have to do is submit the notification of intent to prescribe. Higher prescribing limits still require the 8-hour course. In summary, opioid use disorder is a significant cause of maternal morbidity and mortality. Buprenorphine medication-assisted treatment can be incorporated into both inpatient and outpatient OBGYN practices. Optimizing care for pregnant people with opioid use disorder helps both mom and baby. What happened to Rachel? After participating in outpatient treatment and safe baby court, She regained custody of her kids. She is still in recovery and doing well. I'm so grateful for your interest in treating pregnant people with opioid use disorder. It truly is life-saving and changing work. Please join us for the second session in this series, where we will do a deep dive into how you incorporate buprenorphine prescribing into your practice. Thank you for joining us today.